Hey there, and welcome back to Kidney Cancer Unfiltered. I'm your host, Anne Maria Scaccia, and today we're exploring something that can make a real difference in your quality of life: palliative care. Imagine palliative care as a mansion with many rooms, each designed to support your well being. Some rooms focus on nutrition and fitness, others on emotional support and pain relief. And at the very top, in the attic, is where hospice sits, and that is a space you may never need. This analogy is thanks to our guest Joel Stern, member of the KCA's board of directors and author of My Journey with Stage 4 Renal Cell Carcinoma. Joel shares how palliative care has helped him improve his quality of life and keep up with the activities that bring him joy, like hitting the courts for a good game of tennis, where he's not just playing, but playing smarter. He also points out that, despite its importance, palliative care doesn't always make it onto the doctor's radar. That's why he encourages people to speak up and ask for it. The good news? It's often free and available at the very place where you're already being treated. So tune in as Joel shares his insights on palliative care and how you too can tap into the support you deserve. Joel, thank you so much for joining us on the Kidney Cancer Unfiltered podcast. You know I love chatting with you, so I'm grateful that you're here. For our listeners who are not familiar with you or your story, can you just give a short introduction to yourself?
Thank you, Anna Maria, and the feeling is definitely mutual. I am a stage 4 renal cell carcinoma thriver. I don't like the word survivor. I'm a step above surviving, and I think everybody should have that attitude. I was diagnosed on November 16th, 2020, incidentally found when I went to an orthopod and had an MRI, and they found a 9-centimeter tumor on my iliac bone. And then they did a biopsy, and found cancer that was kidney origin. And then they did other scans and found that I had bone mets up and down from the bottom of my skull to my hip. And been on immunotherapy since day one, have had my kidney removed, have had a radiofrequency ablation, have had 3 rounds of radiation. I have something called oligoprogression, which means that it's the whack-a-mole game. Basically, cancer will pop up, but not enough to change treatment. So we whack the mole. In my case, that's radiation or cement in the pelvis or ablations. But I am starting year 5. I refuse to acknowledge statistics. I'm living life to the fullest. I've experienced an awful lot in the last 4 years and plan on living a lot more to see my grandchildren grow up, Anna Maria.
Yes, I think statistics are meant to be defied. I think for a lot of us in the kidney cancer world, we defy statistics already. So I plan to see you living a very, very long life. And part of your treatment, so the reason why we wanted to have you on, we talked for one of those like virtual patient symposiums. We did like a little interview, and you had talked about palliative care. And you had made the comment about like reframing what we think palliative care is, which is a topic of conversation I'm hearing more and more about in the cancer world, kidney cancer world. So I'd love for you to like dive into what palliative care looks like for you.
No, I'm happy to. Well, let's start off with me being naive. When I first was diagnosed, I saw on a form the term palliative and a recommendation that I seek palliative care. And I went home and sat on my couch and cried and said, "Oh my God, hospice, they're giving up on me." And like many newly found cancers in the RCC area, patients basically believe that palliative care equates to hospice. I'm happy to say nothing could be further from the truth. Palliative care is done ancillary to your treatment. And the way that I frame it, Anna Maria, is you look at palliative care as a beautiful, large mansion. And there are lots of different rooms that you can open and close, and you can go in these rooms and seek some of the benefits that palliative care has to offer. So some of them are, 1, pain management. Our doctors are focused on treating the cancer. Not all of them are equally as good at treating pain. You can find a room in palliative care that will offer doctors and nurses and clinicians that will help you with pain management. There's another room in palliative care, obviously this is virtual speaking, that I call side effects that will help you deal with the side effects and give you their wealth of knowledge almost on a daily basis as you need it. You can come in, you can do it virtually, and I found that very helpful. I was probably one of those he-men that said, I'm too strong, I'll never need therapy, right? I mean, the typical
Yeah.
guy that's too afraid to acknowledge that getting therapy is a strength and not a weakness. Well, within palliative care, they offer social services and therapists that you could take advantage of. Another area that I've taken advantage of is nutrition. So you can open the door within that mansion and find nutritionists and dietitians to help you figure out what is the right diet for you. And by the way, we should also disclaim another myth that's out there. There's no diet that cures cancer,
Yeah.
but healthy
Thank you.
diets for healthy people are good for us that have stage 4 renal cell carcinoma. So when you see things that look too good to be true, they are too good to be true.
Mm.
There is nothing out there that can cure our cancer in the diet world, but there's plenty of things we can do to be optimally suited to be healthy or healthier with this cancer. So, for example, within palliative care, my nutritionist said, eat less red meat, eat less processed foods, eat less sugar, drink a little bit less, and eat more chicken, fish, veggies, and fruit. It has worked for me.
Yeah.
Obviously, if I was diabetic within palliative care, they would offer different things. They also offer help with the financial toxicity of this disease. So in many palliative care centers, you can go in and talk about, how am I going to pay these bills? I'm having trouble with the insurance companies. They keep rejecting it. I need your help. Can you show me organizations within my community that can help me with groceries or help me find an electric wheelchair? So these are the things within palliative care. Now, I should also point out, within palliative care, there is a room called hospice, but it's a
Yes.
room I hope I will never have to open, but God forbid I do, and others do. That is a room of experts with hospice training, both in-house and off-site. But again, that's a very small piece of the puzzle. And that's one of the things we have to convince patients of, that you go to palliative care does not equate to getting hospice services.
Absolutely. And I think what's interesting about that, it just sounds like a very holistic approach to treatment, right? We look at this in the conversation around mental health. You mentioned social services, right? And currently that's another conversation that's happening more and more about how the mental health aspect is missing from cancer treatment. Like we're so focused
Yeah.
on treating the disease that we forget that like treating the actual physical disease is such a small part of the actual experience, and palliative care seems to be the thing that just addresses the actual entirety of that experience, which
Anna Maria, that's an excellent point. And it's a point that doctors have to recognize, right? They are so skilled at helping us survive day in, day out and become thrivers for many of us. But they weren't trained in helping with the mental side, and nor do we really expect them to have that training. But we need help. I've often said that the mental side of dealing with this disease is harder than the physical side,
Mhm.
because the physical side, we know how to treat it. The mental side, how do you reduce your pulse? How do you reduce anxiety? What do you do when you can't sleep? And these are all the things that I've had to go through. And palliative care, I mean, boy, they helped me find a combination of medicines to help me sleep, trazodone and Ambien. But this was after trial and error, and this is after several different phone calls. They helped me with pain management, and basically also routed me to pain specialists. So they may not be the right group to help you with pain management to the nth degree, but they will route you to the right people. And they will also route you on the mental side to very specific mental therapists, psychologists, psychiatrists that have the expertise that you need. Also for your caregivers, because our caregivers go through an awful lot, and they need help in dealing with this disease. So personally, I found the therapy services to be some of the most beneficial. I use it less today than I did day one. Anna Maria, as you know, the
Yeah.
stages of cancer are real: shock,
Mhm.
anger, sadness, depression, and then I'm going to beat the you know what out of this disease.
Yeah.
Well, I wish I was smart enough to have taken advantage of palliative care when I was in the sadness and depression stage, because I didn't really understand what palliative care had to offer 4.5 years ago. But today I do.
And in terms of what it has to offer, who And I think this is probably something that needs to also be dispelled. Who qualifies for palliative care?
Yeah. My understanding is if you're at the cancer center at your hospital being treated for renal cell carcinoma, you are entitled to get palliative care services. And I do know, just like any hospital or any doctor, there are lots of success stories, and unfortunately, there's some not so great stories. But for the most part, and I do keep tabs on this, most hospitals, especially at academic centers, where I personally think you're going to get the best treatment for renal cell carcinoma, they have palliative care centers with most, if not all, of these offerings. Sometimes you have to ask. Sometimes your doctor will tell you about it. So if you haven't heard about it,
Yeah.
please talk to your doctor. To some extent, talk to the nurses at the cancer center. Sometimes they know more about palliative care than the doctors do, but you just got to ask if you're not offered.
And I know you mentioned doctors, right? Like doctors really understanding and knowing palliative care beyond, treating just the disease. So in terms of actually dispelling what palliative care means, right? Like this idea that it's just hospice. How do we do that? Like how do we do that as patients and survivors? And how do our doctors and like the actual medical teams and centers do that?
Well, what a great question. A couple of things. Let's look at it from the hospital's perspective. If you go on Mayo Clinic or Cleveland Clinic or MD Anderson, you will see sections in their cancer units about palliative care. So that's one way. Number two, patients sharing with other patients. The KCA, for example, has an incredible community of patients and caregivers with stage 4 cancer. We need to continually talk about palliative care in my own stage 4 community that I started a few years ago. We have hundreds of people joining monthly, and you have to repeat those messages. And sometimes you feel bad for the old timers that you're talking about palliative care, but you have to appreciate that for many people, this message is very new. We
Yeah.
need to have doctors at kidney cancer sessions have programs that talk about palliative
Mhm.
care. So we need to have the head of palliative care at some of these major hospitals get time with the kidney cancer doctors and clinicians that are at these seminars talking about palliative care services, because this is a little bit hard to acknowledge, but some doctors are not even aware of what palliative care is.
Yeah.
And you find that especially in some of the smaller towns. But it really takes communications. It takes those that are taking advantage of those services to share the benefits of it. It takes podcasts like what you and the KCA are doing to hopefully share it. And it really just takes the doctors to acknowledge that they are amazing at treating the cancer, but maybe not so fantastic at treating all the other stuff.
Yeah.
And many doctors acknowledge that. Some still don't. Some doctors think that they can do everything, but they can't. I have not met a doctor in my long tenure with this disease that can understand dealing with the mental side of this disease. Now, interesting story. I have a doctor that was treating me that recently had a major heart scare. And
Mm.
he communicated with me and said, I finally acknowledge what it's like to be a patient. This
Mm.
is what, unfortunately, fortunately, he's going to be fine, but this is what we need doctors to appreciate. They need to listen to these patient stories more
Yes.
often. And I find for the most part, they're willing to listen, but we need to communicate.
Yeah, absolutely. And it makes me think in terms your comment about doctors thinking that they kind of can do everything. It always makes me think of that saying, jack of all trades, master of none, right? Like
Yeah.
you can be a general, but it doesn't mean you really understand how to do it. And I wonder if there's this element of bringing palliative care and maybe not naming it palliative care, but like bringing it throughout the stages, right? Because like when you're at stage 1, it's really just surgery and you're on your way. Stage 2, maybe the same thing. Stage 3, and maybe that, and maybe some other type of treatment. Um, and those other parts of it, like any pain management, nutrition, like dealing
Yeah.
with side effects or even mental health, those options aren't necessarily there. And it's not to say,
Yeah.
but I wonder if we started having those services from no for every stage, that maybe that's another way like we can kind of dispel what it means, if that makes sense.
Well, your question is perfectly timed. Just yesterday on the Kidney Cancer Association Facebook community, there were a lot of people with stage 1 very anxious and scared,
Yeah.
and all they were focusing on is what if versus why not me, right? Why
Yeah.
not me be cured. And, you know, a year ago, I would have said that palliative care is mostly for stage 4. And then I may have moved back and said maybe for stage 3. Today, it's a little bit novel for me to have this thought. I really think palliative care should be offered at all stages. You have a 39-year-old or a 60-year-old, whatever the age, and they get diagnosed with renal cell carcinoma, they are scared. And I don't know if
Hmm.
you measure their anxiety worse or better than somebody with stage 4, but the point is they are having issues. They are concerned. They don't know what to eat. They don't know how to get help. They don't know when they have side effects, when it necessitates talking to a doctor or palliative care. So I agree with you. I think palliative care should be introduced for everyone that has renal cell carcinoma. But I would suggest to you for stage 4, it should be mandatory that doctors
Yeah.
and hospitals communicate that to their patients. It isn't at that level today. It should be.
Yeah.
Because stage 4, the one thing about that disease that's different for regular renal cell carcinoma is every other person that has renal cell carcinoma has a curative outlook.
Yes.
Their
Yeah.
goal is to be cured. Our goal with stage 4, you can call it anything you want, is to live the longest life possible with quality of life. Call that durable remission with 50 years. But there's no cure. I mean, that disease, most doctors consider there's no cure. And being terminal creates a whole sort of unique issues for patients to deal with and caregivers to deal with that I don't think all stage 1 and stage 2 have to deal with. But I really think that stage 4 mandatory, stage 1 and 2 and 3, it should be offered and discussed.
Yeah, and I think there's always going to be different levels of need, right? But I love this idea of making it mandatory because I think when you do that, you're also again dispelling. I know I keep saying that word, but you're also taking how trying to think another way to say it, maybe take the wind out of the sails, breaking myths or whatever you want to say. But like if you're like, no, as part of your cancer treatment, you're gonna have palliative care,
Yeah.
it's like, okay, it's just part of treatment. It's just something I need to do because of course stage 4 is going to have different needs than stage 1, stage 2, and stage 3, and maybe it is different terminologies, but it's just this idea of a holistic way of care. And it's something that's missing, and it's something we just need to do better at.
It's why I love the house metaphor because it allows people to visualize the fact that hospice is 8 floors up and you may never get there, and there's all these other rooms that you can open and take advantage of. That's why I use the house metaphor because I think it really depicts that issue that you're explaining.
I think it's a fantastic metaphor. I could even see, and this is my graphic designer brain working, but I could just like even see it as this wonderful graphic
Yeah.
of like a nice little blueprint area and just all the areas. But you were talking about the benefits. Out of all of them, which one do you think changed your life the most? Or at least the way you approached your own treatment, your own health, your outlook?
No, that is two, and I hate to do that to you. You know,
It was fine,
as a
I don't.
lawyer, it'll never be as binary as black and white. I think one is being the patriarch of my family and the one that's always counted on to be strong, acknowledging that I'm not as strong as I thought I was, and getting help with the mental side, I think was a huge, huge deal for me, just to take that step and to be open about it and talk about depression and sadness. I don't talk about those things, right? So being the guy that feels like he's stronger than anybody mentally, that has to acknowledge he's not that strong, was a
Mm,
huge epiphany for me. Number two is I have chronic pain,
mm,
and working with palliative care to help figure out how they can handle my chronic pain and take it from a 7 to a 5 to a 4 has been instrumental in me being able to thrive. And that is a combination of strong medicine. I have a pain patch. I take Oxy as needed. It is getting radiation when it's necessary. It is going to acupuncture. And by the way, acupuncture is also in a lot of these hospital websites. It's not part of palliative care, but I was referred through palliative care, so another benefit. And I go weekly, and it really helps with my left hip where my iliac has been destroyed. So pain management plus the mental side, I think, were the two biggest benefits that I've received from palliative care and continue to receive from them.
And we've talked in the past about you being athletic and loving to, exercise and just being active. So how has that pain management helped you continue to enjoy those things in your life?
So coming back and talking to you after playing 2 hours of tennis that I'm now playing 3 times a week, I mean, I've learned to deal with pain. And what
Yeah.
I realized, Anna Maria, and you probably can talk to this as well, that playing tennis is not going to make me worse. Yes,
Yeah.
there's a risk of a bone breaking because I have bone mets, but all of my doctors in palliative care say the benefits of exercise, the mental benefits and physical benefits of doing that greatly outweigh the risk of damaging
Mhm.
yourself further. So exercise for me and being comfortable from my palliative care group that I can play tennis. Now I play with an older group. I used to play with 30-year-olds. Now I'm playing with 50-year-olds. And I guess that was hard to take. But so the tennis game's a little slower. I'm playing doubles, but they gave me the confidence that exercise was not something that I have to run away from.
Yeah.
They gave me the confidence that there's meds that I can take to deal with the chronic pain, but also get that exercise. When I don't exercise, I get sad. I get
Yeah.
depressed. I go back. So when I don't play my tennis at least twice a week, no matter how I feel, it really hits me mentally. And thank God that palliative care not only authorizes it, but basically wants me to get more exercise like that.
I am grateful that you're able to do that. It really is about just increasing that quality of life. And I think that brings up another point. I think for me growing up, I'm sure for you growing up too, cancer was always seen as like this death sentence, right? Like it was, oh, and it's always still in media frame today as like this death sentence, even though we're all living longer and there are a lot more survivors. Um, and so it sounds to me that palliative care, it gives you that opportunity to have that quality of life, right? Like you're going to be living longer. Like why why live in this way where you're just kind of defeated, if that makes sense?
Yeah, and that again goes to the mental side. So I developed these things, but I think therapy helped me. I mean, anxiety for tomorrow just ruins today. We have so many people that are feeling okay today, but they're
Yeah.
so worried about tomorrow, they're not enjoying today. So that's a mantra that I love to repeat. Anxiety is worse than reality for most people. So our anxiety levels, we think the absolute worst, and that rarely happens. It does, but it rarely happens. Again, palliative care helped me in that mindset. And I think, Anna Maria, we talked about this before, but my 30-minute a rule day to deal with anxiety. I mean, I developed it myself, but I think therapy helped me figure this out. We can't get rid of anxiety. It is
Yeah.
there. But what we can do is train ourselves to take that anxiety and just wallow in self-pity and be afraid of everything, but do it for 30 minutes a day. And at the end of that 30 minutes, we block it from our brain. And if we find the next afternoon it's starting to come back, we say, nope, I got to wait till 1 a.m. tomorrow morning to start getting anxious again. So
Yeah.
I have found that my 30-minute a day rule allows me to be anxious, but it allows me to have 23 and a half hours of sanity and enjoyment with my life despite my disease. I learned that indirectly from palliative care and therapy. I mean, the mental side of this and the help that I got allowed me to explore these things and develop these things that help me and I hope help others.
Now, for those who may not, depending on where they live, what access to healthcare that they have, those who may be able to benefit from palliative care, but may not necessarily have access to it, could you, I guess, give advice on how they may be able to go about getting those kind of services? Like, where are some areas, or other than like maybe the KCA, or other nonprofits? What are some ways that patients can try to get those type of services?
So this is called navigating through choppy water. So yes, there are hospitals without palliative care. And in those instances, what I would recommend to patients is we know the hospitals have patient liaison folks that they can talk to. So a lot of the things that palliative care offers, you can get outside through third-party referrals. So get a referral to a nutritionist, get a referral to a therapist. You're basically taking that house and you
Yeah.
basically flattened it, and you have to find separate houses outside that are third party and not affiliated with the cancer center. It can be done. So almost every service that I get within the hospital, I could find a third party to do it. Most hospitals that don't have palliative care will have resources to help you find those services. Maybe hard, but I think it's doable.
So what's a piece of advice you would give? Or actually, since you're a lawyer, it's not binary. What are a few pieces of advice that you would give to other maybe newly diagnosed stage 4 renal cell carcinoma patients who are hesitant to even bring up that conversation of going to palliative care because of whatever preconceived notions that they may have? What would be your advice to them to get that conversation started?
Well, one is convince them that hospice and palliative care do not equate to each other. So
Yeah.
get that out of their system. And that takes reminder after reminder after reminder. Number two is, as a good lawyer, I would tell my
Mhm.
client, what's the downside of trying it? So, what's the
Okay.
downside of trying palliative care? And if you don't get what you think you should be getting out of it, you find those resources elsewhere. But most people love their palliative care groups that are affiliated with the cancer centers. The next piece of advice is the more that you deny that you need these services, the more likely that you do. And
Yeah.
that's the unfortunate part. We still have a view around the globe, specifically with respect to the mental aspects of this disease, that if you can't deal with it, you're weak.
Yes.
We have
Yeah.
to dispel that myth almost more than dispelling the myth that palliative care and hospice are not the same. Because if people are not strong enough to admit that they need help, then they're
Mm,
never going to take that first step. So we have to convince, and basically, I think more men than women, that getting help is a sign of strength and a badge of honor and not a sign of weakness. So
yeah.
those are some of the things that I would work with patients. The other thing, and again, going back to communities, there is so much education. I mean, look at why you're doing these podcasts, right? We get
Yes.
them one body at a time. But if you ask the number of renal cell carcinoma patients around the globe that know that the Kidney Cancer Association has podcasts and has a website that has materials to help patients, navigate through their RCC journey, I mean, those numbers are increasing exponentially because we're
Yes.
talking about this, because we're having these discussions. I would like to see more doctors and heads of palliative care jointly write papers and produce them and get them out in the community. I think that would be a recommendation that I would have for some of the most renowned RCC
Yeah.
specialists. It would be a good thing for them to partner with doctors and write papers like that.
Yeah, I was gonna ask what you think we can do at like a policy level and a research level to help again make it not such a dirty word, right? Like again, and also break apart or at least not view it as this thing that is, hospice being synonymous with palliative care and vice versa. So I think the research part, or at least having doctors write research papers on it, I think that's a really fantastic idea because you can get, that patient perspective and really do like a self-report survey or whatever it is. I know there are proper terms for this stuff. But I think hearing it kind of from the horse's mouth, to use a cliche, can really help other patients like make that step. Because again, it goes back to that quality of life, right?
Well, the good news, and I just saw something that somebody got a grant for. They did research on quality of life, and when you talk about quality of life, it's a very close nexus to what palliative care has to offer. So I'm optimistic that we're heading in the right direction. I do think we need to make this a topic of discussion that's forefront and center rather than behind the scenes. And I wish, in hindsight, that somebody had, like, I wish it was mandatory that I had an hour session with palliative care as I'm being treated with cancer. Another great suggestion, right? Have an
Yeah.
hour orientation session. They can do that one-on-one or they can do it in groups, but it should have been offered as an orientation session.
Yeah, it should just be, that's a really great point. It could just be baked in like, here's your treatment plan. By the
Yeah.
way, here is a session on palliative care, right? Because I don't think, I mean, I work in communication, so it's all about words, and sometimes you need to rename things to get people to like understand it. But I don't think it should be something that needs to be renamed, right? Like, I don't think it's something that
No.
should try to hide in a pretty box with a different term, right? I think for like stage 1 to stage 3, maybe it's more integrative care, right? Just because the needs are different.
Yeah.
But I think, again, I know I keep going to that quality of life piece, but
Yeah.
like you said, like if you don't have those parts in the house and you're not taking advantage of it, then, how are you living kind of? thing.
Well, my takeaway from this, Anna Maria, is you need to create a house with the different rooms and show all the services, and we've got to turn that into something that every hospital and every doctor uses. So, see how I turn that around?
Yes, I love it. And it's a great idea. And I will have to talk to the KCA and be like, okay, this is what I drew. Put it somewhere. It's a nice little graphic of what
And just
palliative
put my
care
name
looks.
on one brick that,
Yes,
I was
yes.
a piece of the puzzle. So,
No,
but I
you
really
would
think,
be as told to Anna Maria by Joel. That's what
yeah,
it will be. That's what the graphic will be.
we can get a patent on it or something.
Yeah.
So, but yeah, I think these types of discussions are what is needed. But I do think the medical side has to have the same types of discussions too.
Absolutely. And I don't know if this is something you can answer, but in terms of policy level, right? Instead, like making it mandatory, I think would be a policy thing. What are other, do you think are other policy actions that can happen in order to integrate palliative care in the cancer journey and the cancer treatment journey?
Well, I mean, hospitals get credentialed, and they get credentialed for cancer centers, and they even get credentialed for like specialties. I think they should get credentialed for palliative care. That should be part of the credentialing. In many states, and I realize we're global, but talking from the state's perspective, there are patient rights that are baked into law. Why not add patients have a right to palliative care and talk about
Yeah.
that? That would be a great way to do it. I think it's more of a pipe dream to say that you're going to see legislative action on it. But
Yeah.
again, the other thing is, pharma companies could help with it too. It would be an interesting way because almost every treatment you get, there are side effects. And
Mhm.
pharma could have a huge impact if they talked about palliative care as a great way to deal with pain management and side effects of these treatments.
So before I let you go, what would be the one thing, summing up our whole entire conversation,
Yeah.
what would be the one thing that you would tell thrivers and maybe newly diagnosed patients about palliative care?
So I would put it this way. Anytime you seek hospice, that is part of palliative care, but not all palliative care is hospice. As a matter of fact, most of palliative care has nothing to do with hospice whatsoever. And that's what I would continue to educate patients and caregivers on. And the last point is, try it. I mean, there's no downside in trying it.
Yeah. And you know what? I know I said before I let you go, but I did just think about the hospice piece of it, right?
Yeah.
I think even though we're talking about kind of like breaking this myth or dispelling this notion that palliative care equals hospice, we also can't deny that hospice is a part of it. And how do we make also help patients to become, I mean, I can't imagine you would ever necessarily be comfortable with it, right? But more accepting of the fact that yes, there is a chance that that might be a room
Yeah.
in the house that you might have to walk into. But just because there's that chance
Yeah.
doesn't mean you don't go view the house. If
No,
that makes
I think you expressed it probably better than I could. I would also say even if you go into that room, you can leave that room. And
that is
people
true.
don't realize that. I mean, when you go into hospice, you stop treatment, but you have the right to open up the door and get out and get treated again. And that's really important, I think, for people to know. Again, the visual depiction, when you show all the rooms and you see hospice is a very small room that is used, that does serve a purpose. I think that's the best way to express it. And hospice is a critical element of palliative care because for some patients, that's where the journey ends, and it's a very comforting, calming, painless way to end their journey. But most of us are never going to open that door
Yeah.
because we're going to take advantage of all the palliative care services and live a long life with quality. And
Yeah.
that's what palliative care is about.
Yeah. And I was going to ask, is there with palliative care, it's also not something that you must be on for the rest, like the rest of your treatment, right? Like you
Yeah.
also, even if it is mandatory, like you still have, or rather, even if in the better, like in a greater world, it would be mandatory because everyone deserves more of a holistic
Yeah.
treatment to their cancer care. But it's also something that you can, as a patient, have the right to be like, you know what? I don't need these services anymore. I'm just going to focus on the treatment itself. Like it's not one of those things where all of it is where you don't have
Yeah.
any autonomy in it, if you will.
You use it when you want it. There are times, like I've probably gone several months without talking to my therapist because I'm fine, but I call them up. They're there for me. I give you just an empirical perspective. I'd say looking at my oncology doctors and using palliative care, I probably talk to palliative care 10 to 1 with respect to communications. Whether it's my chart, whether it's a virtual visit, whether it's seeing them in person, I probably work with them 10 times as much as I work with my oncologist, just to give you a perspective. But it's totally my call. By the way, I've never seen a bill. I've never paid a penny for it personally. I don't know why, but it just seems like it's part of the cancer services. We talked about changing names. I would change the name of the cancer center to something a little bit better. That's a discussion for another day. But I love when it almost kind of rolls around my lips. I mean, palliative care. I mean, it's a good word.
Yeah,
It's
it
not
is.
hospice. It doesn't. You can't palliative hospice. I mean, it's not
Yeah,
hospice. And I think
yeah,
again, we just keep communicating with people,
yeah.
and hopefully
Yeah,
they'll listen to me someday.
I think they will. I think they're listening now because, like I said, it's a conversation that I'm hearing more and more about. And
Yeah.
I think, again, we also have to make sure people understand that um, hospice is a room in the house. It doesn't mean once you start palliative care that
Yeah.
you will automatically end up at hospice. And I wonder if that's also part of it too, where it's like, well, if I do this thing or if I take advantage of these services, then that must mean one day I will be in this room
No.
where it's like, no, yeah, exactly. If you want to expand on what I was just about to say.
No, I mean, think about if you have a mansion, and I don't have one, but I'm assuming for those that have very large mansions, there's rooms they never enter.
Yeah,
There's probably some of them have locks on them. So, yeah, it's not like a journey where you go from A to B to C to D to hospice. It has
yeah.
nothing to do with each room is very independent. You can go in one room and never enter into any other room, and you have total control over that. The other thing I would recommend is that all patients go on their hospital websites and see if there's information about palliative care, because most big city hospitals have sections in their websites about palliative care.
Thank you so much for joining us. I know I asked you this a few questions ago, but are there any other parting words that you would like to share with our audience?
Well, I'm easy to find, and I know you are too. So have patients and caregivers reach out to us via communities or direct messaging or emails. We're here to help. I mean, this is all of us that are patients and caregivers. It's a really warm, compassionate, informative community. So we are here to help, whether it's palliative care or any other questions that people may have. This is the silver lining in this disease is I've met more people, including you, that I consider friends, that we're going to fight together on this disease and ultimately help the doctors make this a chronic disease rather than either curative if it's stage 1, 2, or 3, or terminal with long-term, durable remission. So
I consider you a friend too. And I think thank you for all the strength that you show our community and how you're there for everyone else. And I'm grateful that you have access to services that let you be vulnerable. I mean, you could always be vulnerable at us, obviously, but sometimes when you're strong for others, you need that space to be vulnerable. And I'm grateful that you have access to that.
thank you, Hannah Maria, and thank you, Kidney Cancer Association, for putting on these podcasts. I think they are helping. I know they are helping hundreds, if not thousands, of people.
Thanks for listening to Kidney Cancer Unfiltered. If you found this episode helpful, be sure to like, share, and subscribe wherever you listen to your favorite podcast. For more resources and episodes, visit kidneycancer.org or follow Kidney Cancer Association on social media. Until next time, take care, and remember, you're not alone.